Good afternoon and welcome to session 2 of the Lurie Children's Pediatric Cardiology Roundtable with specialists from our nationally ranked Lurie Children's Heart Center. My name is Chad Worley and I am the Lurie Children's Physician Liaison that serves the north suburbs and the north side of the city. In this session today, we'll be discussing preventative cardiology with Dr. Baptista. But before we get to Dr. Baptista, I would like to encourage you to type in any questions that you may have for him after our session. And then we will discuss these later in the program. Also, like to let you know that in the handout section, we have a couple of brochures about our Heart Center that's available to download if you choose to do so. But without further ado, I'd like to hand it over to Dr. Baptista so he can talk to you about preventative cardiology. And I'm going to share the screen with you now, and you should be in good shape.
Perfect.
You're good to go.
All right, let me see if I can get this.
Looking good.
All right, excellent. All right. So I wanted to say thank you for inviting me to chat with you guys a little bit about preventive cardiology, and I'm going to focus a little bit on dyslipidemia today. Yeah, I'm Guilherme Baptista. I'm one of the preventive cardiologists here at Lurie. You guys should feel free to call me Guy if you'd like. You know, when I was doing my MPH and knowing that I was going to head into pediatric cardiology, I was really trying to find a spot where I would be able to use some of those public health skills to really make an impact on kids' lives. And I think that preventive cardiology is one of those intersections between general pediatrics and pediatric cardiology where we can make some really long-term impacts on kids' lives. And I got excited about being able to offer that here in Chicago as well. So for this talk, we're going to be talking about kind of an evidence-based approach to preventive cardiology, focusing on screening and treatment of dyslipidemias, which was based on our 2011 guidelines. So there's our objectives there, and we're going to discuss the screening approaches to dyslipidemias. We're going to discuss screening, sorry, not the hypertension was on the longer talk. We're going to talk about treatments of dyslipidemia and then review how some of those comorbidities are impacted by pediatric obesity. So dyslipidemia, why do we care? So abnormal lipoprotein metabolism results in increases in total cholesterol, low density lipoprotein cholesterol, triglycerides, and decreases in high density cholesterol. You know what, let me change something here, because I think that the slides that are up are yeah, this is a different presentation. Sorry about that. Bear with me. This is going to be it. All right. So, how dyslipidemia is the treatment of.
Doctor, we don't see your screen.
Okay, here, let me try this again. You know, the toggle here isn't showing up. Would you mind
let's
taking
let me do it real quick.
Yeah,
please. Thanks for your patience, everybody. All right. Hopefully that works for you.
Yep, that worked.
Great.
All right, can you see that?
Here we go. Yep, we're good. We're on your objectives page.
And then we're going to do a case. This is, dyslipidemia. Why do we care about dyslipidemia? This abnormal lipid metabolism results in increases in the types of cholesterols that I just listed, and also a decrease in HDL. They're caused by genetic mutations, they're caused by environmental mutations, or secondary other processes such as kidney disease and organ transplantation. Dyslipidemia is associated with increases in atherosclerosis in adulthood. Childhood lipid levels correlate well with adult levels and the levels of adult relatives. And treatment in childhood slows the progression and reverses the processes that lead to atherosclerosis. And so what I'm trying to get at is that this is a little bit of a paradigm shift. It certainly has been with families when we discuss treating for dyslipidemias, but it is for us physicians as well. And this paradigm shift is that we really have to see coronary artery disease as a childhood process and not just an adult process. So these are the types of primary or genetic dyslipidemias. The ones that we see primarily are just the FH, whether it's homozygous or heterozygous. We see a lot of familial combined hyperlipidemia, and these are the subtypes here that we don't have to get too deep into the woods with. And then we see quite a bit of familial hypertriglyceridemia and even some severe hypertriglyceridemia. These are some of the secondary causes of dyslipidemia, and the list is fairly extensive. Some of the ones that we see more frequently in our practice when we get referred to us are dyslipidemias related to steroids or acne medication, sometimes even within our own colleagues when we prescribe beta blockers. We see a lot of diabetes, hypertriglyceridemia related to diabetes. We see some PCOS as well. And a lot of kidney disease that leads to dyslipidemias. Obesity is obviously a really big one. Certainly over the last couple of decades, there have been shifts in our patient populations where once we were maybe, more so dealing with genetic predisposed dyslipidemias, and now we just see a lot of environmental causes, and that is really associated with our increasing incidence of obesity. I'll say that the most commonly when we have kids coming in for dyslipidemia or hypertension that's related to obesity, the dyslipidemia pattern that we see is that we see a moderate to severe increases in triglycerides. We see normal to mild elevations in LDL-C, and then we see reduced HDLs. And the rest of the labs, we most commonly see slight increases in ALT, and then obviously changes in glucose and hemoglobin A1C. This pattern of obesity-associated dyslipidemia is also independently associated with atherosclerosis in adulthood. So what happened about 10 years ago, or a little bit over 10 years ago? Well, what happened is we switched from a selective mode of screening to universal screening. And we did that because the selective screening missed about 30 to 60% of children who had a genetic predisposition to dyslipidemias. And now we recommend that all children should be screened, the risk factors that those children have can help us determine what age the screening should be accomplished. So the ages that we use at this point is that there's no lipid screening from birth to 24 years of age. There's no routine screening from 2 years to about 8 years of age. Although in folks that are at high risk, so for instance have a family history of dyslipidemia, kids between 2 and 8 and 12 to 17 can also have lipid profile for screening as well. And then that 9 to 11 years of age, right before adolescence, right before puberty, really is the sweet spot for screening. And I'll get into that a little bit later in the presentation. So this is kind of how to interpret the results in our panels. Let's focus a little bit on LDL, triglycerides, and HDL-C. When I quote these numbers to families, I say 110 is the number that we should use as normal for LDL. For triglycerides, I usually use 100, although they're a little bit lower in these kids, and then you'll see higher acceptable range in older populations. But 100 is an easy way for folks to remember that, and it's a reasonable number to use as well. And then for HDL-C, it's 45. This is important because it helps us, the risk factors help us determine threshold for when we would recommend treating. They mostly just make sense, right? These are risk factors that we've used for a long time as risk factors for adults for cardiovascular disease and coronary artery disease. So family history obviously is a big one. MIs, angina, cabbage, sudden cardiac death, and I even add in a family history of familial hypercholesterolemia in this. That would be a high risk factor. Other high risk factors would be hypertension that requires therapy, smoking. BMI greater than 97th is technically what we should use, although I use obesity as a high risk, although obesity, the 95th to the 97th is a moderate risk factor. I just use it as a high risk factor. And then the presence of high risk conditions, which are listed a little bit below. And then there's some moderate conditions that are listed there as well. Hypertension that doesn't require therapy and HDL less than 40. And then these moderate risk conditions that are listed below as well. So the LDL algorithm is as follows. Before really these patients are referred to us, what should be happening is that they get two fasting lipid profiles, and you average the results of those lipid panels. Usually what happens is that kids, a fair number of kids end up having at least those two lipid panels before they come to us. I think it's perfectly fine if the lab values are abnormal enough that after one lipid panel they get sent to us. And the numbers that we're looking for where you you can start primary treatment as an LDL greater than 130. Again, even before they get to us, is a LDL greater than 130 or less than 120 than 250. The reason why they use range is that for some of the LDLs higher than 130, it's reasonable to start just lifestyle type interventions. The guidelines actually, they do a pretty good job of talking about these thresholds that I use myself to make a decision along with the parents for starting pharmacotherapy. And the way that we break it down for family is that anybody really that comes in that has an LDL of 190, again, average over 2 measurements, they get started on statin therapy. So they get pharmacotherapy. If you have one risk factor, anything added into the mix, or 2 moderate risk factors, that threshold drops from 190 to 160. So if you have a kid that comes in with obesity, that qualifies. If you had a kid that comes in with a family history of dyslipidemia or heart disease, that qualifies to lower the threshold to 160. And then when you add any more high risk factors, or if you have 1 high risk factors and 2 moderates, the number drops from 160 to 130. This is a summary of what I just discussed here. For triglycerides, I think that it's easier to kind of focus on this slide down here. I'll tell you that, you know, with us seeing a lot of kids with hypertriglyceridemia, any number of triglycerides that's elevated all the way to 250, I always really focus down on lifestyle interventions. And those lifestyle interventions often means trying to lower the weight, and then limiting simple carbohydrates and sugars. Once you start getting to the 250 range, we start adding in a kind of a stepwise fashion, depending on how high the triglycerides, and we start adding omega-3 fatty acids. Depending on the size of the patient, I go up to 4,000. In the younger kids, I usually start at 1,000 to 2,000. And if the triglycerides are high enough, usually I use around 500 as a threshold for that. I would use something like a fibrate, like fenofibrate, to treat. And again, this is that exact summary. So pharmacotherapy. So for LDL, statins are the mainstay. In kids that are hard to treat, we sometimes add on ezetimibe. And then in the kids that are very, very difficult to treat, we use PCSK9 inhibitors, which tend to work really, really well. I can tell you that in our practice, we only have a handful of that we've had to transition all the way to PCSK9 inhibitors. For heterozygous FH, we start treatment. I would say most lipidologists would feel comfortable starting treatment as early as 8. For some of the more severe cases, we have started even earlier than that. The earliest that I've started was 6 years of age, and I've helped manage a kid that we started as early as 3 years of age. With homozygous FH, you can start a statin, but the statin actually doesn't usually do a whole lot of good, and you have to move on to PCSK9 inhibitors or LDL apheresis, and often they end up requiring liver transplant if things are bad enough. The way that we evaluate them, I will repeat a baseline lipid panel when we first start pharmacotherapy, and I also get baseline LFTs as well. Some folks do a CK at baseline, although I don't do that myself. And then at around 1 to 2 months of age, I'll repeat a fasting lipid profile and LFTs. And then about 3 months after that, then 6 months, and then we space it out to about every year as we get stability on their current dose. The adverse effects that we usually see are that we discuss would be muscle cramps, some weakness, really symptoms that are suggestive of myopathy, although kids rarely, if ever, have these symptoms that we worry more about in adults. And in my practice and in my experience, and this is, you know, with quite a few kids that are on statins, just based on what we do, I have maybe a handful of kids that have had symptoms, and those symptoms were probably not really related to the statin therapy. With triglycerides, you know, the initial thing is, like I said earlier, carbs and decreasing sugars. We start maybe some omega-3 fatty acids, which tends to be well tolerated, and then we move on to fibrates, which we tend to get fairly good results with. So what I'm going to do is I'm going to go over a couple of cases for us, and this is actually one of the cases that we presented for the pediatric pearls a little while ago. So you see a patient who's 11 for his annual exam. It's around 2 p.m. The mom knows that he's going to get his COVID shot and maybe flu vaccine. So she treats him to a little bit of fast food before going to the visit. He eats a double hamburger, he has some fries and a pop as well. And when you guys get there, even though you know that he's not fasting, it's a good opportunity to get a cholesterol. So you have a point of care test available, and you send that anyway. And so what I want to get from you guys is what you guys will think that the changes to these types of cholesterol, subsets of cholesterol, will be just based on whether this kiddo is fasting or non-fasting. So if you guys want to chime in, that would be great. What do you all think is going to happen to the total cholesterol based on him not being fasting? Is it going to go up? Is it going to go down? Or is it going to be about the same? Or
Feel
can
free
we?
to
Can
raise
we?
your hand in the, yeah, feel
Yeah.
free to raise your hand, folks, in the area, and I'll unmute you.
And this may be difficult to pull off. So for the total cholesterol, I would expect that actually to be about the same. For the triglycerides, the triglycerides is one of the labs that is highly impacted by fasting versus non-fasting status, and highly impacted in general about the types of foods that kids eat. So for the triglycerides, I would expect that to be elevated, falsely elevated. The HDL stays about the same. Sometimes we see it a little bit lower if the triglycerides are really significantly elevated. The LDL, the VLDL is a number that's derived from the triglyceride. So if that is, if the triglycerides are elevated, the VLDL is going to be elevated as well. And then the LDL number is actually going to be decreased. And the LDL number doesn't actually change. The actual LDL in the patient doesn't change. But since the LDL is a number that's calculated rather than measured, and the triglycerides are used in this calculation, because the triglycerides go up, the LDL comes down. So that kiddo gets his labs drawn at 11 years old, and then little Jimmy comes back at 12 years old to follow up on those same labs. 4 months before his actual appointment day, you guys rechecked it, and his lipid panel looks as followed. He has a total cholesterol of 286, an LDL of 199, a HDL-C of 27, and a triglyceride of 282. For this repeat, the mom thought that he might have been fasting, although she wasn't really sure. He has a fairly significant family history. His mother has elevated cholesterol, and she takes medicine. She doesn't remember exactly what it was. The maternal grandfather had a cabbage at a young age, and he takes multiple meds for cholesterol. And then he had a maternal uncle that is reported to have elevated lipids as well. But the father is actually in fairly good health. He was a term infant. He has no past medical history. There's no exposure to tobacco or vaping products. He attends school in person. He's in sixth grade. He averages between 8 and 9 hours of sleep and doesn't nap. He plays basketball, baseball, flag football. He has school and gym. He's very active. No screen time. He has a new cell phone, but doesn't spend a whole lot of time on that. He's overall doing all the right things as far as that's concerned. His food and beverages choice, because of the grandfather's history, the family has actually tried to make quite a few changes. Eats 3 meals a day, 1 to 2 healthy snacks, eats fruits. He's getting better with the veggies, lean protein, eats some fish. He snacks on fruits, nuts, and some dairy. He has some small portions of primarily whole grain, and then he really tried to cut out the sugary beverages and has maybe a couple of treats a couple of times a week. His physical exam is overall fairly unremarkable. His BMI is in the right around the 93rd percentile. So we repeat his cholesterol in our clinic, and the total cholesterol is 274. His HDL is a little bit better at 50. His LDL is actually a little bit increased at 217. You look at his triglycerides, they're actually significantly improved at 84. The triglycerides can be improved because maybe they have been working a little bit on the diet, but also it's very possible that he wasn't fasting when he had that repeat lab, and now he is, and you see a significant improvement. His hemoglobin A1C is a little bit elevated, and the rest of his labs are fairly unremarkable. So next step. So I left this as a question, but I'll just go through this as well. So diagnosis, this looks and feels a lot like familial hypercholesterolemia, and it looks and feels a lot like heterozygous familial hypercholesterolemia. And I say that based on the LDL being elevated and the family history in a kid that you wouldn't otherwise expect to have high cholesterol. Lifestyle and food choices, how's that going to impact him? I think that's critically important for Jimmy, right? And I say that because I think that the most important part of what we do in our clinic is to overall improve cardiovascular health. And the cholesterol component of things is only a small part of cardiovascular health. So although the lifestyle and food choices may have some impact on his LDL being elevated, it's not going to make it perfect, but it may actually make it easier for us to treat his dyslipidemia, and it's going to be overall important for cardiovascular health in the future. For some of these kids, it's actually really, really important because they may very well be borderline on, whether they're hitting the threshold. And if we can bring their LDL down by 10, 15 points, it might actually bring them to below something that would require treatment. And then medical management. So in this situation, I think a statin is more than appropriate. He's had multiple lipid panels now where his LDL is elevated. It's elevated well above his threshold to treat. And this is one of those situations where we can make a significant impact on the kid's cholesterol profile with only a small dose of statins. So we follow them up about 2 months later. Again, we recheck the cholesterol 1 to 2 months afterwards, and Jimmy's doing really well. He's compliant with the atorvastatin that we started. We use atorvastatin more because of experience than anything else, but it tends to get really great results. He reports no symptoms. He's still working on eating more veggies, and he's actually started to do some yoga as well. And this is his lipid profile there. So you see a really nice improvement in his LDL-C. His HDL is actually even a little bit better. It's not all that uncommon to see HDLs that are fairly robust in kids with FH, and he kind of fits that profile. His triglycerides are a little bit better as well, and statins do have a bit of an impact on triglycerides as well. And then the rest of his labs, I would say that the liver enzymes are slightly higher, but still within the normal limit, which isn't all that unusual when we start statin therapy. So a couple of things to consider here, specifically with Jimmy's case. One is the age to treat, which we got a little bit into earlier. I think that most folks doing what we do are very comfortable to start treatment at 8 for just about everybody. The guidelines actually say 10. The guidelines in Europe go with that 8 cutoff. And then I would say that a good chunk of us would actually consider start treatment even earlier than 8 if the cholesterol and the family history is bad enough, okay? The goal LDL that we would use for treatment, ideally I want to get that LDL number lower than that 130 threshold. If they have enough risk factors and that threshold to start is 130, I usually try to get them under 110. I would say that we're not as aggressive in the pediatric population as adults are in the adult population. In the adults, there's no such thing as a low enough LDL, and there's even talk about getting LDL close to 0. In general, am very happy with getting kids' cholesterol, LDL cholesterol below 110, and for the kids that have where we started off at an LDL, closer to 200. I at least try to get them to an LDL of 130. One of the things to think about is the effects of puberty on cholesterol. This gets back into why we recommend checking cholesterol in that 9 to 11 age range. It's been well described that as kids go through puberty, their LDL can actually drop a little bit. So if we check their cholesterol during that puberty range, their LDL cholesterol may actually be falsely reassuring. So we may miss some kids that have true dyslipidemia by getting a cholesterol at that age. And what I would say about that is that if you see a kid that has never been screened, it's okay to screen them if they're in puberty. You just have to take into consideration that number may be a little bit falsely reassuring. So even if it's a little bit elevated, there's a reasonable chance that a few years from now, that number is going to creep up, and they may actually get into a range that's within treatment level. People often ask about LFTs, and we do see some increases in LFTs with statin therapy, but they really have to be quite high for me to get excited about this being a cause of statin therapy, or for me to choose a different agent to treat dyslipidemia. And we're talking about 5 times the upper limit of normal before we're within that range. I've never seen kids get to that point with statin therapy. We often have questions about rhabdo as well. In my practice, and with my experience with folks, and I actually polled some of the other preventive cardiologists in our group as well. We have maybe a handful of kids that have complained of muscle pain or weakness, but that tends to have been in the setting of, getting bumped up in soccer practice or something along those lines. And we have not switched any of our kids from statins to something else because of those symptoms. But the options would be to send some labs like a CK. We could pause the statins for a while and see if they're improved. We can decrease the dose, although kids generally get a very good response on a very low dose, or we can switch to a different type of statins to see if it's better tolerated. Again, in kids, because we get such a good response on such a low dose, and because I think the kids metabolize it a little bit differently than adults, we generally don't see any side effects associated with statin therapy. I have in the past, both from families and providers in the community, been asked about other long-term effects of statin therapies. And I think that maybe out of all the things that we've studied with statins, maybe the one where there might be a little bit of signal after population studies is that maybe statins have a very, very, very slight increased risk for diabetes. And when you dig into the data a little bit more closely, it tends to be the folks that have higher risk for diabetes to begin with. And in those folks, we'd be monitoring very closely regardless. The conversation that I have with family members when we start statin therapy in kids, because there is that bit of a paradigm shift, is that we know, based on very large studies, that statins reverse some of the changes that are associated with high cholesterol, basically the health of blood vessels in general. And we've known that for quite a while. We know that it's fairly safe in kids. And then more recently, within the last couple of years, we've seen some studies coming out looking at population wide studies looking at the decreased incidence of coronary artery disease in kids that have been treated with statins starting at a very young age compared to their parents with similar lipid profiles that weren't started on statin therapy. And that decreased incidence is something like 8 times less coronary artery disease. So it is a very robust impact that we can have on the long-term cardiovascular health of kids by impacting at a young age. Any questions that you guys may have in general about dyslipidemia in kids, cholesterol in general in kids, or the treatments of dyslipidemia in kids? I'd be happy to open kind of the floor for questions.
Thank you so much. That was a really great presentation. The case studies were fantastic and I'm sure very helpful. So
Sure.
I'm going to go ahead and look at the question. I'm sure it'll give people a chance to type them in. I do know that we had one question asked earlier that looking for maybe a hypertension talk down the line that we can do, because I know that is a question. Yeah, that is a topic of that people want to talk about as well. So.
Yeah, the other half of this talk, I tried to trim down even the talk to fit it into 30 minutes. I did a Pearl a few years ago when the AAP came out with the new hypertension guidelines. and kind of we broke down what those guidelines were like, some of the changes that came with those guidelines, and I think that there were actually really positive changes. And I thought that the guidelines were fairly well written, but it's you know, useful information to have. It's high yield.
Okay. Well, you can assure that I'll be reaching out to you for another talk, and we'll make it on hypertension. Okay. But it looks like we're in good shape here. I think, you know, as we discussed earlier today before we started, that you already had answered a bunch of questions before they asked them. So so I'm going to go ahead and thank everybody for joining us here today. And if you want to contact Dr. Baptista, his phone number is here. It's the general cardiology line is 312-227-4100. You can email him at gbaptista@luriechildrens.org. There's Epic and Rapid Connect, and then of course there is Lurie MD if you want to reach him. I'd like to remind you all. Oh, go ahead. Sure.
We have preventive cardiology clinics. I personally go to the main hospital downtown. I go to Arlington Heights. We go to Grays Lake. I go to the Lincoln Park location as well. And we cover the kind of the north and northwest fairly well. We're trying to expand a little bit south as well. And you know, one of the things that we've increased access with is with telemedicine. And actually, familial hypercholesterolemia is one of those that lends itself quite well to telemedicine visits. So it's always an option for some of the patients that are a little bit farther away from here as well.
That's great. I really appreciate you telling us that. That's excellent information. I'd like to remind everybody that we did record the session, and they'll be sent out to you to review again if you so wish. And I'd like to remind you that we're going to continue on with our pediatric roundtable series with the Lurie Children's Heart Center tomorrow, as Dr. Sedigat will be talking about syncope at 7:30 in the morning, and then we'll be introducing our POTS program team of Jillian Myers and Dr. Jarrett Linder at 12:30. So we hope you can join us, and we will see you tomorrow. And take care and enjoy the rest of your day. Bye-bye.
Thanks so much.
Thank you.